dues will carry over to the next April and the total amount will be sent as intimation. Since half-yearly payment is decided by State Council, I cannot say officially that it is optional. Another advantage is continuous money flow will help the financial position of the scheme also. Anyway, kindly forward this to State Office also and let the leadership give a final ruling on this matter. We will be happy to follow that. Dr. Shyam D. Gopal, Secretary SSC reply ആണ് ഞാൻ വായിച്ചത്. നമ്മൾ സ്റ്റേറ്റിൽ സ്റ്റേറ്റിലോട്ടൊന്നുകൂടി അറിയിച്ചോളൂ. പിന്നെ നമ്മൾ പ്രധാനപ്പെട്ട പരിപാടി വുമൻസ് വിംഗ് ഓഫ് കണ്ണൂരിന്റെ നമ്മുടെ പുതിയ ഭാരവാഹികളുടെ ഇൻസ്റ്റലേഷൻ ആണ്. അതിനുമുമ്പ് ഞാൻ കഴിഞ്ഞ വർഷത്തെ പ്രസിഡന്റ് ഡോക്ടർ മീന മാഡത്തിനെയും സെക്രട്ടറി ഡോക്ടർ ബീനെയും സ്റ്റേജിൽ കഴിഞ്ഞ വർഷത്തെ IMA പരിപാടികൾ കണ്ണൂർ IMA പരിപാടികളിൽ ഏറ്റവും പ്രധാനപ്പെട്ട ഘടകം വുമൻസ് വിംഗിന്റെ പങ്കാളിത്തം തന്നെയായിരുന്നു. അപ്പൊ അവരുടെ നിർലോഭമായ പിന്തുണയോട് മാത്രമാണ് കഴിഞ്ഞ പരിപാടികളൊക്കെ നന്നായിട്ട് വിജയിച്ചത്. അതിന് വുമൻസ് വിംഗിന് ഞങ്ങളുടെ പ്രത്യേകം നന്ദി അറിയിക്കുന്നു. അസോസിയേഷൻ ആയിരുന്നു എനിക്ക് പറയാനുള്ളത്. ബാക്കി
അതിന്റെ അപ്പൊ അതിന് പറഞ്ഞ പ്രധാനപ്പെട്ട മേഖല അതിലെ കുറച്ച് ആർട്ടിക്കിൾസ് നമ്മള് കോൺട്രിബ്യൂട്ട് ചെയ്യാൻ വേണ്ടി ആൾക്കാരാണ്. അപ്പൊ അവരാണ് കുറച്ച് ആർട്ടിക്കിൾസിന്റെ ക്ഷാമമുണ്ട്. അപ്പൊ അത് നമ്മൾ ആരെങ്കിലും പറ്റുന്ന ആളുകൾ ഉണ്ടെങ്കിൽ കുറച്ച് കൊണ്ട് കഴിഞ്ഞാൽ ഡെവലപ്പ് ചെയ്തിട്ട് അവർ സ്പെഷ്യാലിറ്റികളിൽ താല്പര്യമുള്ള ആളുകളുണ്ടാവും. അത് മാത്രമല്ല എനിക്ക് തോന്നുന്നത് മറ്റൊരു പ്രസിദ്ധീകരണങ്ങളിൽ നിന്ന് വിഭിന്നമായിട്ട് ഏകദേശം 10,000 കോപ്പിയാണെങ്കിൽ മെമ്പർമാർ പ്രസിദ്ധീകരിച്ച് കൊടുക്കാൻ വേണ്ടിയായിട്ടുണ്ട് 10,000 കോപ്പി പോകുന്നുണ്ട്. നമ്മുടെ മീറ്റിനെ പെട്ട് കഴിഞ്ഞാൽ ആളുകൾ ഉപയോഗിക്കാൻ പറ്റിയ I invite past president MNAMS to introduce the install the new officer.
President Dr. Suresh, Secretary Rajmohan, and Prince. കഴിഞ്ഞ ഞങ്ങളുടെ ടീമിന്റെ ഇൻസ്റ്റലേഷന്റെ ദിവസം ഞാൻ ഉണ്ടായിട്ടില്ല. ഞങ്ങൾ ഓൾറെഡി പ്ലാൻ ചെയ്ത മാതിരി ഒരു ടൂർ പോയതായിരുന്നു. അപ്പൊ ഏതായാലും ഈ പ്രാവശ്യത്തെ ഇൻസ്റ്റലേഷന് എന്നെ തന്നെ ഏൽപ്പിച്ചിട്ടുണ്ട്. ഞങ്ങൾക്ക് കഴിഞ്ഞ കൊല്ലം നമ്മുടെ നമ്മുടെ പാർട്ടിസിപ്പൻസിന്റെ അടുത്തൊന്നും നല്ല ഒരു സഹകരണം കിട്ടി. എല്ലാവരും തന്നെ ഡോക്ടേഴ്സ് ഡേ സെലിബ്രേഷനും അതേപോലെ തന്നെ നമ്മളെ നോർത്ത് സോൺ കൺവെൻഷനും എല്ലാവരും തന്നെ നന്നായിട്ട് പങ്കെടുത്ത് പല കലാപരിപാടികളും സ്കിറ്റും ഡാൻസും ഒക്കെ നമ്മൾ നന്നായി ആസ്വദിച്ചു. പിന്നെ ഞങ്ങള് നോട്ട് സോൺ മീറ്റിംഗ് ഉണ്ടായിരുന്നു വിമൻസ് വിങ്ങിന്റെ തലശ്ശേരി. അതിനും നമ്മുടെ ഇവിടെ നിന്ന് ഒരു ഡാൻസും ഞങ്ങൾ 10 പേര് പങ്കെടുക്കുകയും ചെയ്തു. ഇപ്പം പുതിയ പ്രസിഡന്റ് ആയിട്ട് ഡോക്ടർ ആശ റാണി, സെക്രട്ടറി ആയിട്ട് ഷാഹിദ കേരി. അന്ന് സ്റ്റേജിലേക്ക് വൈസ് പ്രസിഡന്റ് സത്യേന്ദ്രൻ, ബാക്കിയുള്ളവർ ഇവിടെ നിന്നാ മതി. അല്ല ഇവിടെ നിന്നേ. ജോയിന്റ് സെക്രട്ടറി ഡോക്ടർ അനിത ആശിഷ്. എക്സിക്യൂട്ടീവ് കമ്മിറ്റി മെമ്പേഴ്സും ഉണ്ട്. ഞാൻ പേര് വായിക്കാം. ഡോക്ടർ നീന ജയറാം, ഡോക്ടർ ധനലക്ഷ്മി, ഡോക്ടർ ഹൃദ്യ, ഡോക്ടർ മഞ്ജുഷ, ഡോക്ടർ രശ്മി മാത്യു, ഡോക്ടർ ഹേമ ദിനേശ്, ഡോക്ടർ ബീന കെ, ഡോക്ടർ ഭവ്യ രാകേഷ്, ഡോക്ടർ പ്രിയ ശർമ്മേൽ, ഡോക്ടർ മീന, ഡോക്ടർ ശ്വേത കെ. എല്ലാവരും ഇങ്ങോട്ട് വരണം എല്ലാവരും. ഈ പുതിയ ടീമിനും എല്ലാ ഭാവങ്ങളും ആശംസിക്കുന്നു. എല്ലാവരും സഹകരണം നേടി.
Next is CME. Today's speaker is Dr. Rakesh, consultant Infectious. Infectious diseases, PMS and Meitra Hospital. I invite Dr. Rakesh to come with us. Introduction of the speaker by Dr. Calicut.
എന്നെ ഞങ്ങൾ ഇരിക്കുന്ന IMA-യിലെ ഈ വർഷത്തെ ഭാരവാഹികളായിട്ട് എലക്ട് ചെയ്തതിന് നന്ദി. പഴയ ടീമിനെ പോലെ തന്നെ ഞങ്ങൾക്ക് നല്ല രീതിയിൽ നടത്തിക്കൊണ്ടുപോകാൻ പറ്റും പ്രതീക്ഷിക്കുന്നു.
It's a great honor to introduce Dr. Rakesh TP, consultant in infectious disease at Meitra Hospital, Calicut, and BMH GIMCARE. And he has done his MBBS from Calicut Medical College and MD in internal medicine from Government Medical College. He holds a DNB in internal medicine also. He completed his internationally recognized 3-year fellowship program in infectious diseases from Hamad Medical Corporation, Qatar. And he has also passed the MRCP UK specialty exam in infectious diseases. He was a former assistant professor in medicine in medical education department, Calicut, and now, as I already mentioned, works as a specialist in infectious diseases at the BMS GIMCARE Hospital as well as Meitra Hospital. The infectious disease is a rare specialty as of now, and we are delighted to have you here and listen to your wisdom on this occasion of World AIDS Day.
Good evening, all. I thank all the organizers for having me here to give a lecture on HIV. My experience includes working in the government sector, the HIV Affairs Center, Institute Medical College. We had around 3,000 HIV patients, live and total 5,000 patients. So today, HIV is another chronically manageable disease. In the late 1980s, this virus was isolated and people used to die with severe immunosuppression. For several years, there was no treatment, just like leprosy and old leprosy TB. And gradually, we have excellent treatment with their drugs. Initially, they gave monotherapy, then dual therapy, then triple therapy. Now we have excellent, very useful drugs with least side effects, and they can have just normal life with just one tablet a day without any much side effects. It is just another disease like hypertension, diabetes, and kidney heart disease with excellent survival, almost unlimited lifespan. Okay, so I will divide my talk into this current epidemiology, pathophysiology, clinical course, just an outline, then current treatment options. We will highlight the post-exposure prophylaxis and what will be the future of HIV treatment. See, so far, the HIV has taken a toll of around 40 million people. They are dead so far. Just remember that COVID has taken 6 million. Okay. So this is a silent pandemic going in the background of COVID, HIV, TB, and we are almost used to it. And 2021, around 6 lakhs people died from HIV cause, okay, and 1.5 million acquired HIV, okay, 15 lakhs. And with excellent mortality reduction with antiretroviral treatment, more than 80% mortality reduction, okay. The prevalence, the worldwide prevalence is 0.7%. Meanwhile, India, it is declining. It is currently, it was 0.21% in general. Okay, because several years back it was 0.6. Now it is declining with excellent antiretroviral treatment and less spreading. The global situation, in India, you must remember that is 0.2, but it is not the same in the rest of the world. Okay, the main HIV lies in sub-Saharan Africa. It is believed that these Africans, they are very prone for HIV. That's why it is rampant there. And the incidence ranges up to 27% in Botswana, Swaziland, in some of the South African countries. 27% is the prevalence of HIV, because 1/3 people are positive with HIV. Okay, and the death caused by HIV. See, the cardiovascular diseases rank 1, followed by cancer. HIV is somewhat in around here, 11 or 10 will come. Okay. In India, the prevalence is highest in the northeastern states. Mizoram, Nagaland, Manipur. The prevalence rate is around 2%, 2 to 1%. Okay, and but the number of people are maximum in Maharashtra and Andhra Pradesh and Karnataka. Okay, around 3 lakhs each, approximately. And this is a natural course of HIV. Okay, so once after this, here the primary infection. Okay, this green line is the HIV viral load. The virus immediately goes in a peak. Okay, this is the early viremic phase of this HIV, producing acute HIV syndrome. It is very infectious at this point of time, occurs within a period of 3 months. So this is the CD4 count, this is our immune marker. So immediately there is a decline in CD4 count, disproportionate, proportionate to the viral load. After that, it increases, the viral load decreases and enter in a chronic replicating phase, this virus. Okay. Over several years, in a mean period of around 8 years, the CD4 gradually declines and the viral load gradually increases. Okay. At this point, when the CD4 reaches around 300, patient becomes symptomatic due to they start showing the features of immunosuppression in the form of small infection like oral candidiasis, recurrent herpes, etc., etc. And as the disease further advances, the viral load increases and the CD4 decreases, resulting in severe immunosuppression. At this point, we call it as AIDS, advanced, immunodeficiency syndrome. Okay. The rate of decline is around 50 per year. Okay, it's 50 per year approximately. So by around 300, patient develop oral thrush. Then TB comes around 200 to 300. PCP around 200. Histoplasmosis, coccidomycosis, cryptococcosis, all comes around 100 and less than 50. Okay, so this is the general course of the HIV. Okay, so until that patient will become asymptomatic. So these are all original photographs I saw in clinic. Nothing is lifted from internet. Okay, just to show you how the HIV will look like. This is the most common infection in HIV, called oral candidiasis. Okay, most common, usually appears less than 200. The appearance of oral candidiasis suggests very advanced immunosuppression. It won't appear in just like that. The treatment involves just giving fluconazole. It will immediately disappear. 100 to 200 milligram OD for 7 to 14 days. The candidiasis will disappear. This is a patient with cryptococcal meningitis. You can see the lateral rectus palsy here. He's not able to look outwards. Usually appears, this patient is having basal meningitis. Usually appears in less than CD4 less than 100. Remember that all the features of meningitis is not seen in HIV due to very advanced immunosuppression and very minimal inflammation. So next difference is seen only 1/3, and interlink may be positive in 3/4. And antigen latex agglomeration antigen is more sensitive. So this patient was given amphotericin and fluconazole. The treatment involves amphotericin and with flucytosine, and later the consultation phase involves giving fluconazole, high dose fluconazole, and this patient has this lactose palsy was resolved. Okay, and you need to give prophylaxis with fluconazole daily till the CD4 count is more than 200, just like in PCP pneumonia. This is pneumocystis jirovecii pneumonia. Now it is classified as a fungus. Usually appears in less than CD4 less than 100. Patient typically present with cough, breathlessness, and diffuse chest pain, and unexplained weight loss. You may get very vague symptoms. An X-ray will typically show perihilar infiltrates. So remember that most common X-ray finding is a normal chest X-ray in PCP. Okay, so you can see the perihilar infiltrates in the patient with PCP pneumonia. This is herpes genitalis. Recurrent herpes genitalis is one of the hallmarks. Usually appears around CD400. You may give acyclovir 200 to 400 milligram for a few days. It can recur. The definitive treatment will involve ART. Once you give ART, this will disappear. This is herpes labialis. It is, you can see the swollen lips. Sometimes you will get a lesion of the tip of the nose. Okay, this is herpes labialis. This is extensive herpes zoster. So remember that usually in HIV, the herpes zoster is multi-dermatomal. Okay, so when you see multi-dermatomal herpes zoster, always think about advanced immunosuppression, especially HIV. And if you see multi-dermatomal herpes more than 50 years, it's an indication to do an HIV test. Okay. So you can see the multi-dermatomal herpes. You can see the herpes on the trigeminal nerve, severe herpes. This is cytomegalovirus retinitis in the patient with very advanced immunosuppression. You can see a small hypopyon here. See the retina. You can see the small hypopyon. This is molluscum. This is called giant molluscum. Usually seen in around CD4 less than 100. And a giant molluscum on the face is said that it is diagnostic of HIV. So just remember this photo. It's a very giant molluscum. It's the molluscum in the forearm. Okay, giant molluscum. This is another patient with giant molluscum. And the treatment is giving antiretroviral treatment and it will gradually disappear. For example, you can see the molluscum of this patient disappearing with an effective antiretroviral treatment. Tuberculosis, the patient is at around 100 times more compared to a normal person. He is very susceptible for tuberculosis and one of the major causes of death in patients with HIV. And the control of tuberculosis involves controlling the HIV also. Otherwise, we won't be able to control the TB. So they accelerate each other. When the patient is infected with TB, it will bring down the CD4 count. Okay. Even in normal non-HIV patients, it has been found that if they are infected with TB, the CD4 count can go down till 300, enough to produce oral cancers in some patients. Okay. So most of the patients are sputum negative. They tend to be a miliary TB. So this is a patient with a huge lymph node. Okay. And TB immune reconstitution. It can be really troublesome in patients with HIV. As the immunity improves, this improving immunity launches an inflammatory response against TB. So what happens is already the small lymph nodes will get enlarged. Okay, so it will give an appearance that the anti-TB medications is failing. You will think that maybe the patient is having drug-resistant TB. It is not actually. Even it will expand and rupture. Okay, that is called immune reconstitution inflammatory syndrome seen with HIV TB. So this is a patient with extensive lymph nodes, supraclavicular lymph nodes with TB. See, as the treatment was started, it started enlarging. Really troublesome. Huge lymph nodes. See, over months. But somehow, after some time, it will gradually resolve. You may have to give steroids sometimes. Just resolve. Rash can be due to HIV and as well as due to drugs. Nowadays, we are not seeing this nevirapine rash. It is in approximately 10% of the patients. Now we are no longer giving nevirapine, so you may not see this nevirapine rash. Okay. So these are the a few photographs from the HIV clinic. These are all my patients. Now, there is free treatment option available for any HIV patients. As you must know, the government is providing free treatment. All the ART medications are giving. There are more than 500 ART centers in India now. They are giving CD4 testing, viral load measurements, counseling, and all the first line and second line antiretroviral treatment and treatment for opportunistic infection as well. So if the patient is taking treatment from the private setup, it will cost approximately 3,000 to 4,000 rupees per month. So assessing this is extremely important. Always any patient should be offered a treatment from the government sector. If at all he is not willing to go for a government sector, then only he will keep starting for the medications. So should we screen HIV for every patient admitted for surgery? So this is a debatable question, but the general trend is that even the WHO is recommending that you need to screen every patient who is admitted for surgery with an opt-out strategy. So you need to explain this that we are, because the WHO says that this is an opportunity to screen for HIV and you may be able to pick up an early HIV patient. Okay, that's an opportunity. So every patient should be offered this opt-out option. If he is not willing, okay, it's okay, it's up to you. So the WHO is recommending opt-out strategy for the HIV testing. So antiretroviral treatment. Previously, we used to treat this when the resources were limited. The evidence was not that strong. We used to treat the viral load was less than 200. Later, it increased to 300, 350. Later, it increased to 500. But now we are giving treatment for all at any time. It is like a test and treat strategy. There are several studies which show that excellent mortality reduction if you start treatment at a very early stage, irrespective of the CD4 count. Okay, so the current this thing is to treat at irrespective of the CD4 count. So, what are the treatment options to consider before you initiating the antiretroviral treatment? First, remember that it is never ever an emergency. Okay, even if the patient is having secondary opportunistic infection, PCP, whatever, the treatment of HIV is never an emergency. Okay, because it will take several weeks and months to recover the immune system and for the viral suppression. So, it is never ever an emergency. And always check the willingness, affordability for a sustained treatment. This is very important in our setup because if you stop the treatment after 2 months, then the virus will immediately become resistant. And he will have to opt for the second line treatment, which is very, very expensive and the options are very limited. It's not like US. So the affordability and his willingness for a sustained treatment should be assessed upfront, and referral to government facility should be offered before initiating the in the private sector. And all addictions like alcohol addiction should be settled, and you should be willing to accept the treatment. And all treatment, all the opportunistic infection should be treated as far as possible. There are some exceptions, like previously we used to wait for 2 months for the anti-TB treatment to pass that this intensive phase. Nowadays, if the CD4 count is less than 50, you may start the treatment in within 2 weeks. And look for resistant testing only if the patient is previously experienced. It may not be necessary when the patient is new to treatment. Okay. So now we have so many drugs for in the part of this antiviral treatment. This is a nucleoside and nucleoside reverse transcriptase inhibitor that is a previously this old pseudobudin, abacavir, and tenofovir. Now we are moving to tenofovir, alafenamide, which having less side effects. Then MNRPs we have efavirenz, nevirapine, rilpivirine, etc. This is protease inhibitors. We have atazanavir, ritonavir, darunavir, etc. We have fusion inhibitors, enfuritide. These are not available in India. Now, integrase inhibitors are the latest medications which having excellent resistance barrier to HIV. These are very, very effective drug with minimal side effects. Then CCR5 antagonist as maraviron, attachment inhibitor for bosentan. And there is a monoclonal antibody as well. Then injectable combination. This is a new one. Okay. So the treatment involves giving 3 drugs. This is the recommended line. The one from this NRTA. Usually we select tenofovir, alafenamide, or emtricitabine or lamivudine, along with any of these 3 classes, either protease inhibitors or an NRTA or integrase transfer inhibitors. But now we are preferring this Inf.Dis, that is dolutegravir based therapies. This is the preferred line of treatment, once daily medication. What are the new things in HIV? Now, this is a new introduction. There is a 2-drug regimen. You can treat it with lamivudine and dolutegravir. You need not go for the 3-drug regimen. Okay. This is done in selected situations. There are certain criteria for giving a 2-drug regimen. One is the viral load should be less than 5 lakhs. There shouldn't be any evidence for transmitted resistance. And there shouldn't be chronic HBV infection, and there shouldn't be any drug interaction. So you need to do drug resistance testing for this giving 2-drug regimens. Okay. Long-acting injectable. This is a new addition. You can give long-acting cabotegravir plus rilpivirine injection once in every 8 weeks. Okay, so these are given for patients who are very reluctant to take tablets or otherwise forgetful, who don't want to reveal their HIV status by exposing the tablet. So they can go for injectable once in 4 to 8 weeks. Okay? Once in 2 weeks. Monoclonal antibody is a new addition, that is Ipalizumab. This blocks entry of the virus into the CD4 count. Okay? These are not available in India. Okay, so that was the treatment part. So we will just move on to PrEP and PEP. Okay, PrEP stands for post-exposure prophylaxis, and PrEP stands for pre-exposure prophylaxis. So this pre-exposure prophylaxis is given in very selected situations, like in community-based prostitutes, etc., where high risk of getting a transmission, couples living with HIV, discordant couples. Okay, so we will discuss about post-exposure prophylaxis, whom we should consider for post-exposure prophylaxis. So you can divide this post-exposure prophylaxis into two, that is occupational or non-occupational. Okay. So what is the risk for exposure of this HIV? Okay. So the highest risk of exposure is with blood transfusion. If you are transfusing 1 bottle of blood, it is 100% certain that you will probably get an HIV if it is infected with HIV. Okay. And next comes the receptive vaginal intercourse, which is around 0.2% per exposure. Needle stick is around 0.3. Okay. And mucous membrane exposure is at least 0.09%. Okay. So after this blood transfusion comes the receptive anal intercourse. Okay. So needle stick injury, this is the most common type we see in the occupational listing. This is the most common. The risk is around 0.3%. That is 3 per 1,000. Okay. So the incidence we have data from US from 1985 to 2013. It is extremely rare actually. 58 confirmed cases with 150 possible with the needle stick. Okay. And after that, with effective post-exposure prophylaxis, it is very, very less. Only 1 case has been reported. There has been no cases reported with exposure of blood into the intact skin. So you need not worry about this. So what are the things you should do after this needle stick injury in the occupational setting? Immediately, you should wash it with soap and water, just like if you get a raw bruise. And small wounds and puncture can be washed with this sanitizer and povidone iodine. And copious water should be used to clean the mucosal surface or eyes. Okay, saline or water you can use to clean the wound. Squeezing the wound may not be a good idea because squeezing will produce more injury to that area. It might invite this more WBC, which will carry this virus. So you need not squeeze the wound. Okay. And these are the types of fluid which contain these WBCs along with this HIV, that is at risk, like synovial fluid, CSF, pleural, peritoneal, pericardial, amniotic fluid, blood, plasma. And urine, saliva, this vomitus, sweat, they are not considered as this infectious fluid unless they are visibly contaminated with blood. Okay. What about if the source person is not known? Suppose a person has taken blood and he has disappeared. You cannot trace a source person. What will you do? So that depends on assessing the risk. Okay. So, for example, if the person is very drunkard and is having some high risk behavior, then you may ask the person who got the pick to take the post-exposure prophylaxis. Okay. So in high risk situation, you can start the prophylaxis and stop later. If you can trace back the patient and ask him to come back and do the HIV testing, you can stop the this medications. So regimens, you can start within, preferably it should be started within 2 hours of needle stick. Okay, but you can go up to 72 hours, and some authorities say that you can go up to 1 week. Okay, because it may, some of the virus, it may circulate for a while before getting integrated into the centric lymph nodes. Okay, and you need to give these medications, whatever medication you are giving for first line for HIV is given for post-exposure prophylaxis. Okay, it's the same thing. That's it, for dolutegravir for 28 days, 1 tablet per day. Okay. So how you are going to do the follow-up for a person who has initiated the post-exposure prophylaxis? If you get a needle stick injury for a staff and all, baseline, you should do an HIV test. You don't know his previous status. Okay. And it should be started, all the baseline investigation should be done like RFP and LFP. And he should be started this medications. And for 72 hours, you need to review for any adverse effects. Then at 2 and 4 weeks, you need to review with CBC, LFP, and RFP just to see any adverse effects. So when you are going to do the HIV testing after the exposure. So it is done at 6 weeks and 4th month. You should do the latest ELISA for the HIV. And if it is negative, then you will discuss it. But in the selected situations, suppose the patient is having HCV exposure along with HIV, then this the HIV manifestations antibodies development can get delayed. And in this situation, we need to test at 12 months. And do not do HIV PCR. This is very, very important because sometimes you may get false positive with HIV PCR. Okay. So after this needle-stick exposure, you do not, please don't do HIV PCR, RT-PCR, don't. So efficacy of post-exposure prophylaxis, it is very, very efficacious, highly efficacious because when the pseudovirus monotherapy was used, there was 80% risk reduction in studies show. Okay, so when you are using triple drug therapy, it's going to be almost 100%. Okay, so I will just discuss 2 cases regarding this HIV testing and all from UK. This is a 30-year-old male. He was found to be ELISA positive. Okay, 9 months back, and he did a Western blot. It was advised. It was intermediate, indeterminate, plus or minus 9 months back. 5 months back, before coming to my clinic, he was found to be ELISA negative, but Western blot still remained indeterminate. Okay, and he did a PCR. Now he has done ELISA. This ELISA was done from an immigration center from Gulf. It was negative. Now he is confused. He is having HIV ELISA positive. And after that, Western blot is still indeterminate. So he is going to get married and he needs a certificate that he is not having HIV. So what to do? So the interpretation is that, see, the ELISA was initially it was positive. Western blot is indeterminate. Okay. Later ELISA was negative. So there is a good chance that this could be a false positive, which is confirmed by a negative PCR. Again, further ELISA is also negative. So this is not at all HIV. Okay. So I have a certificate that there is no, the current test does not show that he is HIV positive at the moment. You don't know what will happen tomorrow. Okay. Okay. This is another patient with 57-year-old male. He was found to be HIV positive. Along he had bleeding PM. So he was found to be adenocarcinoma rectum. Okay, along with HIV. So we started him on antiretroviral treatment immediately with the tablet. And he improved within 1 month. He declined surgery and he was given chemotherapy. Okay, and everything went well. He received 6 cycles of chemotherapy. And 1 year follow, there is no malignancy and no viral load is due. So he has gone through this ordeal even with HIV. So just want to show that what are things we can do with the latest antiretroviral treatment. So future therapies can be cure HIV. Okay, there is one well-known patient called Berlin patient. He was having leukemia. He was also having HIV. So he underwent a bone marrow transplant. Okay, so this bone marrow transplant, the donor was having a receptor mutation and CCR5 receptor mutation, which will make this HIV resistant to entry into the cell. So after some time, his HIV gradually disappeared and he is free of disease. There is one more patient like that. So the current treatment is, the latest one is a T-cell vaccine. This is a therapeutic vaccine which will induce immunity. And it showed excellent response even after 24 weeks. Patient was out of antiretroviral treatment. This is very, very promising. It is coming. Okay, undergoing trial. Okay. Then it is said that when you are, why we need to give the lifelong therapy? It is found that some of the HIV virus go and remain dormant in the mesenteric lymph nodes, or lymphatic system. So there are drugs to activate the hidden HIV reservoir so that you can cure HIV. Trials are going on. There is a new technology called CRISPR technology, gene editing technology, by which you can create the receptor mutation and cure HIV. China, they have produced babies with the mutated CCR5 receptor who are HIV new, but it is totally unethical. They have been shown to have some side effects. So this is Pradeep Kumar Singh, a man who shed his HIV tag to become bodybuilder champion from Manipur. Okay, so he is showing the power of the antiretroviral treatment. He is Mr. Manipur. Okay, thank you.
Thank you for the opportunity for the excellent presentation. The topic is often
So, sir, you are experiencing a change.
This one of the stage, still blood donation needs to do antibody.
Yes.
There is a different period. How to prevent this patient?
Yes, sir. Nowadays, we are doing 4th generation ELISA. 4th generation ELISA, which also picks up P24 antigen. So that is a lag in only 2 weeks. So we will be able to pick up this tradition 2 weeks. But before 2 weeks, I don't know.
No, what during the speed book here, especially anybody.
No, this antigen. More than the ELISA contains P24 antigen.
It was an excellent presentation. One point I want to add is we had a training, I think 2011, we had a training by WHO on this training. For hospital staff, especially nursing staff, 2 advices what WHO recommend is never recap.
Yes, yes.
Second one is to if needed, you do with single hand recap.
Yes, yes.
So that should be emphasized in every hospital as a prevention measure. Rather than going for the other point is taking this medicine for 30 days is a very costly thing. I had an experience. So that is why I am telling we do what this is for a patient. And every positive patient patient. And it was last to our face. So that is why we took 1 month this medication over 6%. It's negotiated, it's terribly. So the best point is don't recap. If you want a recap, do it with the single hand. That was the message given by the that should be emphasized. That is how to do it. Single hand, you can which is you place recap the level and do it single hand. The problem is what is happening is if you are doing this, you can go to the physical area. And the dangerous thing is this need for need is very, very infectious than that of our single bite.
Yes, the follow is because it contains blood. Otherwise, the surgical needle does not contain blood. Okay, so the surgical is almost zero.
I recommendation for the IFM members it should have take one class at least for nursing staff and nursing assistants of our institutions regarding this how to prevent this middle injury and
even I have seen so many nurses doing this in the
certificate for marriage or a child suspicious patient. Is it not better than you inform the group partner that you are tested partly of God? I am more bothered about your health. After some time, you prove to be HIV positive, and then you be seen heavily. So it's better that we inform the other partner, going to the partner also. It's preferable for you because your safety is more important than safety of anybody else in school.
But sir, we need to help these people using science and evidence. We are the people. So I have given that the current test does not indicate that he is having HIV at this point. I didn't say that he is not having HIV.
Your safety is in your part.
Yes.
You can help anybody without getting injured yourself.
No more questions. What of thanks, please.
We may express our sincere thanks to Dr. Rakesh TP for his excellent and informative session on HIV on this World's HIV Day. Thank you, Dr. Rakesh. Also, thank all members of Kannada IMA for participating. Thank you.